A very warm welcome to everyone joining us today for the second session of the Journey to Resilience, a GLC4HSR Peer-to-Peer Learning webinar series. We launched this monthly series last month. Last month was the first in this series, essentially to enable focused discussions on priority health systems themes, drawing on evidence, implementation experiences, and expert perspectives from different contexts. The inaugural session examined the role of robust assessment and monitoring systems in strengthening health governance. Today's session, titled Policy, Strategy and Planning, Learning from Practitioners, takes that dialogue a few steps further. Beyond sound design, the success of health policies depend on strategic planning, coordinated implementation, adequate financing, continuous learning, and accountability. Today's discussion will explore how evidence, routine data, governance mechanisms, and local implementation experiences can strengthen policymaking and planning. It will also examine how the gap between national priorities and action at the state, district, facility, and community level can be addressed. It is now my pleasure to introduce our moderator and panelists for the session. Today's session will be moderated by Dr. N. Krishna Reddy, CEO of Access Health International. He's a senior practicing cardiologist and health systems expert with over 35 years of experience in healthcare. His work spans clinical excellence, healthcare delivery, health system strengthening, medical technology, and institutional leadership. He has been closely involved in advancing people-centered approaches to improving healthcare access, affordability, quality, and outcomes. Moving on to our panelists, we are honored to have Dr. Hala Zaid, a healthcare leader with more than 33 years of experience in health reform, healthcare management, and medical education. As Egypt's former Minister of Health and Population, she has led major initiatives, including the country's hepatitis C elimination program and the rollout of universal health coverage. She has also contributed to strengthening Egypt's vaccine production capabilities through various leadership roles. Her recognitions include the Harvard Medical School Award for improving medical education in Egypt and being named amongst the 100 most influential women in Africa. We are also honored to have Dr. K. Madan Gopal, a seasoned public health professional with over 3 decades of experience in health sector reform and health system strengthening across India. He has led major reforms in Chhattisgarh, strengthening institutional capacity, workforce development, and primary and secondary healthcare delivery. Formerly, as senior consultant at Niti Aayog, he helped develop 5 editions of the State Health Index and contributed to the Aspirational District Program, District Hospital Rankings, Ayushman Bharat PMJ, and the National Digital Health Mission. He also supported the implementation of the Rashtriya Swasthya Bima Yojana, or the RSBY, for which he received a national award, and advanced reforms in medical education, urban health, senior care, and medical devices. He currently advises state governments on governance, capacity building, and evidence-based policymaking. Himani Sethi is a public health professional with over 20 years of experience in strategic planning, program management, and health systems advisory. Her work spans primary healthcare, public health insurance, maternal and child health, and system strengthening. She has led multi-state programs supporting Ayushman Bharat reforms and spearheaded public-private partnerships for primary healthcare in underserved communities. Her work in Rajasthan received the National Health Mission Leadership Award for Transformational Primary Healthcare in 2016. We also welcome Professor Bhuputra Panda, a public health specialist, academician, and health systems researcher with more than 25 years of experience. He's a professor at KIIT University, Odisha, senior advisor at Access Health, and director of In Order the Health Systems Institute. His work covers health systems and services research, adolescent and reproductive health, child health, community trials, and program evaluation. His research and policy contributions in malaria, tobacco, and women's health have informed national and subnational reforms. He has led over 20 research grants as principal investigator and more than 5 as co-principal investigator, and published over 30 peer-reviewed papers and 25 project reports. We are grateful to all all our speakers and to each one of you for joining today. The session will begin with a moderated panel discussion followed by an audience question and answer segment. Please share your questions in the chat through the session and we will take them up during the Q&A. With that, I invite Dr. Reddy to please set the context and take the session forward.
Yeah, thanks, Tuti, and welcome to my panelists and speakers, eminent speakers, and also a hearty welcome to all the participants who joined online from different regions. As it was articulated last month as well, we are exploring the theme around how health systems are governed, because how they govern influence how the health systems perform. And as the premise of GLC, I mean, we don't hurry through the learning process because these sessions are meant to be of learning and nurturing that culture of learning across the various stakeholders of health systems. That makes a huge impact in how these learnings are put into action, because some of us may be drawing some insights from these learnings and putting into action. So the theme of governance, because many times we are exposed to the healthcare provider system dominantly. Now increasingly we are exposed to healthcare payer system as the health insurance has become a dominant mode of purchasing. Though we comment repeatedly that governance is an important element of health systems, the stewardship, which is one of the building blocks of health systems, we don't understand as well as the other components of health system. Many times, for many of us, it is a black box because we don't know how the decisions happen. At the decision-making level, it may be at a global level, at a regional level, national level, or subnational level. So there is a process of decision-making. I mean, some of systems have evolved process of decision-making, which are based on robust evidence, robust engagement of other stakeholders. Some of the governance systems are not so. That means even the type of governance system, whether it is a democratic system, whether it is an autocratic system, whether it is a theocratic system or a dictatorship or a monarchy or a single party system or a multi-party system, I think all these things have a relevance on how the decisions are taken. So today's actually the session with the speakers here, I wanted to steer this discussion mostly around the policy making, how actually the policy making happens. Because once the policies are made, then they get translated into strategies and action plans. Those are the next consequences of policy cycle. So we have a good mix of speakers. I mean, the selection was made based on the actual decision maker, Dr. Hala being a former health minister, and she was involved in some of the major policy decisions when she was the Minister of Health in Egypt. So similarly, we have Dr. Madan Gopal, basically who was working with the knowledge partners to the decision makers in India. The Niti Aayog, which is the apex planning body, is the knowledge partner to the Prime Minister's office in terms of the decision making for the nation. Similarly, the National Health Systems Resource Center, the NHSRC, is the knowledge partner to the Ministry of Health, the National Ministry of Health, and they have the state equivalents of SHSRC at a state level to advise the state ministries of health. So it is a government knowledge partner. At a global level, we have WHO. Of course, we don't have a speaker representative, WHO as the knowledge partner to the global members of the World Health Assembly right now. So WHO plays that role of a public knowledge partner in generating evidence and in suggesting recommendations to the decision makers. On the other aspect, we have non-government agencies, which are equally important from any decision making. So for that, Himani, since she has been handling many convening of policy dialogues. I remember in 2018, there was a manthan related to the national health policy and Ayushman Bharat implementation. So that there was a policy dialogue in Delhi. That was at a mega scale, but subsequently she has been convening various stakeholders to address some of the unmet health needs of people. And how the non-governments actually contribute to the policy making by these policy dialogues. And lastly, of course, a representative of policy research, health systems research, Dr. Bhuputra Panda, with his rich experience in research. We would like to hear how a non-governmental policy research, at the request of governments or at the request of non-governments, will inform and influence policy making. So this is how the panel has been selected, so that there is a well-rounded discussion around actual policy making. So with this brief context setting for this today's session, I start with Dr. Hala. The first question I just wanted to ask and explore how the priority setting happens, because every unmet health need is crying for policy attention. It may be rare diseases, it may be congenital heart disease, or it may be heart failure, or it may be the tuberculosis or HIV or hepatitis. So there are so many needs. I think everybody is putting pressure on the government and the decision makers that our needs to be prioritized before anybody else. So there may be a mechanism of priority setting. There may be some guideline framework, how you arrive at a priority. For example, Dr. Hala has been recognized and as a responsible singular figure in Egypt for elimination of hepatitis, the first country in the world to eliminate hepatitis. So how that I will be asking her later as to how that policy was translated into action, but more importantly, how that decision was arrived at in terms of the priority setting when they selected hepatitis elimination as one of the priorities. Not that there are no other priorities, but just wanted to explore how this happens in actual policy making, since you are in the midst of policy making. Dr. Hala, over to you.
Thank you, Dr. Reddy, for this great opportunity, and thank you for your invitation. I'm very happy and honored to be between a distinguished panel, Dr. Manda, Dr. Panda, and my dear friend Himani. I miss you so much, and thank you, Statue. Let me to share with you that when I had been appointed to be the Minister of Health at the mid of 2018, the government objective and the president objective at that time or assignment was the universal health insurance, implementation of universal health insurance. So the law had been issued from the parliament, and there is essential to implement this presidential program and establish the organization. I started to put this as priority, but to prepare, while preparing the organizations and establishing the organizations, the payer provider and the accreditor, I started to work on the ground to make this universal health insurance feasible and applicable and sustainable. So, Egypt was at that time the first or the highest prevalence of hepatitis C in the world. So I identified what is the health problem with economic, health, and social burden, and I started with hepatitis C. But while we launched the 100 Million Healthy Lives campaign to eliminate hepatitis C from Egypt. I decided to take this as opportunity to also test the people from non-communicable diseases and make a digital platform with database. So with hepatitis C testing and the treatment, we tested the people from diabetes, hypertension, and the body mass index and treated all the positive cases. Why hepatitis C was the highest priority in Egypt? Of course, we have a lot of burden of diseases, but why? I will share with you some figures. We were the highest world prevalence, more than 4.1 million cases reported in 2015. At least 200,000 new cases annually, and more than 40,000 deaths annually. And according to the World Bank report, 3.8 billion US dollar is the expenses or expenditure on the healthcare, on the hepatitis C and its complication. But at that time, the national health expenditure were 1 billion US dollar. So 3.8 annually, I am talking about more than 70% of this is out of pocket from the families. So it's very high burden on the families, on the socially and economically. The scale of the burden, we are talking about not only 3.8, but this 3.8 was represent to 1.5% of the GDP of Egypt. And the domestic budget for the on the healthcare at that time was less than 1%. Not only this, but also there is a drop, average drop 1.5% of the GDP because of hepatitis C. Annual drop 1.5%. The productivity of the people approximately they loses about 7.5%. The cost of treatment used to be increased, and the poverty, the people who become poor because of hepatitis C 5 times the cause of poverty because of hepatitis C. I would say there is no single family in Egypt without a single case, at least from hepatitis C. So before 2018, hepatitis C was not just a health statistics. In Egypt, it was a 3.8 billion drag on our economy, a driver of poverty for millions of families, and the reason of life expectancy was falling. It was the single largest solvable threat in our population health and our national productivity. So why elimination? The scale made in a national threat, because it was a national threat. The economic case, it was an economic case. And at that time, there were opportunity with curable treatment. And so it's a solvable problem and a vehicle for broader health system gains. Egypt did not have a hepatitis C problem. It had the highest prevalence, as I mentioned. So the decision factor was not the moral argument alone. It was the World Bank had quantified that it is a burden. And of course, the World Bank financed and supported this elimination with $265 million as a loan over 40 years with grace period 5 years. So we did the elimination with $265 million over the payment over 40 years and grace period 5 years, instead of expenditure of $3.8 billion annually on such problem. Unlike many non-communicable diseases or chronic condition, the hepatitis C become curable. And our domestic pharma companies produced the treatment with 39, the 3 years course with $39. And at that time, it was $85K in America and $22K in the Gulf region. So the affordability of treatment was there. So by bundling the hepatitis C and the non-communicable screening, the campaign was not a vertical, it was a vehicle for the population level primary care screening. And starting from that, we build our data and our database, the first health database for people in Egypt. We choose elimination because for once, the health case, the economic case, the science all pointed at that same direction at the same moment when a curable disease is also your biggest economy drag, the decision makes itself. The discipline is in the execution. So this is the why we decided to start with this public health initiative, to prepare the ground for the universal health insurance. Few will implement the universal health insurance with such a burden, not only hepatitis C, but non-communicable disease. Of course, the financial sustainability will be very difficult. So this is why we put this as a priority, and the execution was very complicated. It's not only the affordability of treatment or curable treatment, but also the supply chain, the digital transformation, the communication with the people to convince them and reach people to go to participate. So we screened the target population, which is 60 million.
Dr. Hala, may I interrupt here? Before we venture into the actual implementation of the policy, I wanted to explore further in terms of, because you presented very compelling argument in terms of why it needed the elimination and why there was a priority, both the medical reason as well as economic reason, I think. But whether this was influenced by the evidence generated as a report by World Bank, or is it because the elected members, representative members in the legislative body, they brought it up, or is it because the president himself or herself wanted this as? So I'm just exploring the other inputs into the decision making. In addition to your own final judgment, as a health minister, you're taking the final judgment, but where the inputs came from, there might have been patient groups or any civil society organizations or any research or legislative elected people discussed in the legislative body. So I'm just trying to explore the process of this decision making, because the reasons are compelling, as you explained, in terms of the economic value for $200 million investment. You're avoiding $3.4 billion expenditure. I think that's a great economic value in terms of the investment, because most of the policy decisions are also influenced by the economic decision. But the process leading to this priority setting of hepatitis elimination, is it a multi-process, pronged process, or it was a president was interested, so the decision was taken? So because these things happen in different governments.
Yeah, the decision happened when with the first interview with the president, when I put the universal health insurance, because when they interviewed me to be a minister, they told me your objective is to achieve the universal health insurance and to establish the organizations and blah, blah, blah. So I put in my presentation the universal health insurance as a target. But to achieve this target, I put the hepatitis C, the education, the public health initiatives, the localization of medicines and vaccines in Egypt as pillars. And His Excellency told me that according to WHO recommendation, Egypt should eliminate hepatitis C by 2030. I told, if you can achieve this by 2020, it will be great. I told him this is infectious disease, and we need to implement the universal health insurance, so we don't have luxury of time. But what I need from your end, Your Excellency, and from the Prime Minister is the support. This is not my. This is not the only task for the Minister of Health. It is the task for the cabinet, for the parliament people, for the NGOs, for all the Egypt to achieve this target. With the discussion, the burden of this disease, the affordability of treatment, the logistics, the supply chain, and how can I achieve, he totally supported this mission. And without the political support, I would say we will not even to do the pilot. So because a lot of ministers of health tried to do some practice in this direction, but they didn't achieve because there is no political support. But the clear vision, we need to implement the universal health insurance. It's mandatory. Please do. I told them there is a prerequisites. We need to make it sustainable. So the intervention should start with the public health initiatives. And on top of this initiatives is the hepatitis C and non-communicable diseases. And of course, to convince the top people with such intervention, you have to have the solution, not only curable and medicines that your local companies can produce, but also I discussed with, before this meeting, discussed with the World Bank, because they allocated $500 million for blood safety, donation for blood safety in Egypt with the previous minister. So I went to the World Bank and discussed with them, can we allocate some of this money for the hepatitis elimination? And they approved. So when I discussed this with the Prime Minister and the President, I discussed highlighted the social health and economic burden, highlighted the financing model, the curable domestic products, but I asked them for political support and to engage all the parliament and the cabinet to work together with me and even the local people everywhere. And this is the secret of how to achieve a national health or whatever national objective is to convince and to share all the people with all the data.
Thanks, Dr. Hala. I think I will come back again to explore further on some more questions related to this. Again, harping on the same topic, I will now reach out to Dr. Madan Gopal. Because Niti Aayog or NHSRC, I mean, they generate a lot of evidence, very strong evidence, and they present it to the policymakers, sometimes the parliamentary committees, the legislative body committees. I just wanted to know from a real world experience, how much of the important decisions depend upon the evidence that is sought, whether the policymakers seek the evidence or whether the advisory bodies actually try to communicate that evidence in a fashion that they can understand and impress upon the decision making. Madan Gopal, I think because you were in the center of that process, it will be interesting to know how actually this works in a government agency to support the policy making.
Thank you, Dr. Reddy and Global Learning Collaborative for Health System Research for conveying this important peer-to-peer learning session. It's a privilege to join this session. Thank you very much for that. When we speak about the health system governance, we are not only speaking about the government structures or administrative rules. We are asking a more fundamental question, as you have already put in. How do we convert the complex and unequal health needs of the populations into priorities, budgets, services, accountability, and measurable results? This is a core question which we ask, that how we can address the unequal health needs of the population. People in the south, they require a different kind of need. They do have a different health need, whereas the other states, the northern or the northeastern parts, so they usually have a different kind of thing. So that we have to factor in the population based on the priorities, the budget requirement, the services, accountability measures, and how we are able to measure the required. This is where the institutions like Niti Aayog, National Institution for Transforming India, which was earlier known as Planning Commission, and when we followed the sovereign model, wherein the 5-year cycle planning was used. Now, after the devolution of finances, this institution was created to at least nudge the states, guide the states in the spirit of cooperative federalism and collaborative way to shape the country's aspirations and other things. Then the National Health System Resource Center, which is an apex policy think tank for Ministry of Health, and the other research agencies and technical support institutions and the State Health Resource Center, which you have mentioned in your opening remarks. Their role is not only to merely produce reports, because you see that how the policy cycles happen. They must perform at least the 4, I think I can list out few of the following functions. One is they have to generate credible evidences. We want to shape anything, we have to create credible evidences so that it can be interpreted, the evidence can be interpreted in the policy context. Then we have to bring the different stakeholders together, and are we able to create feedback loops with this kind of intervention, which is the implementation experience which informs the next policy decisions. We have to see that how that can be there. During my time at Niti Aayog, for example, I was involved in 2 programs, which talks about the data-driven governance. So, for example, the State Health Index, which you have mentioned during this, because Niti Aayog was an institution to inculcate the habit of competitive, the collaborative federalism, and cooperative federalism, and competitive federalism. That means you have to create a competition between the states so that they are nudged to perform in the spirit of the cooperative federalism. The state health was not only intended to rank the states, it was used to bring comparable evidences and discussions into the states, identify areas of relative strength and weakness, and encourage both accountability and competitive federalism. Because when we were releasing this during the first round, people could not understand what we meant. But after the second and the third this reports, which third edition of the report when we published, then lot of narrative, the perspective, and other things were created. And we used to be called by the different state governments asking, we are also spending the same money, but why we are lagging? And that has resulted in a discussion. And this is the true spirit of the competitive federalism and collaborative things. Apart from that, the other program was the which the evidence and the reports they have made was the aspirational district program, which now is this. Because the evidence was there, if you want to achieve the sustainable development goals, we should be having a we should not be spreading out resources too thin, because the best performing anyway would be best performing, but there will be few counties or the districts which won't be performing at par with the best performing. The idea was that if you are able to invest whole focused efforts into this state in the districts which are not performing better, so that's why the whole focus and whole contest of aspiration district program came in. And based on the success of that, now we are having aspiration box program. That means we have to see that how the indicators move collectively, so that the evidence which has been created, that if you are able to prime this movers of that particular indicators, the things will happen in that direction. At NFHRC also, the process operates closer to the implementation, because we are technical think tank. We are supporting the implementation of National Health Mission, which is one of the biggest flagship program of the Government of India, focusing on the preventive, promotive, and other services. So mainly using the field experiences, we are trying to see that how the field experience is bringing. We do a routine program review, then we set in standards. We have state level consultations, which helps us translate the policies into operational strategy. You think about the this RBSK program 2.0, that is based on the insights and the inputs based on the field level insights. The Anemia Mukt Bharat 2.0 program, the Poshan Abhiyan and other things, all are based on the things which we get from the field. And based on that, the programs are tweaked. The real value of a public policy institution, therefore, lies in not ability to, with the data, with decisions, but we have to see that how the data which is to be translated into decision, and it becomes a grounding point. Apart from that, they have let me list it at least 3-4 major policy development which has happened in the country. First is the national health policy. If you talk about that, before that there was a policy. 1983 was there, 2002 policy was there, but they were more or less focusing on the family planning. First time in 2017, we focused on a comprehensive healthcare approach, so that encompassing the different thing. It talked about the pluralistic and citizen-centric approach for healthcare services. So at that time, when the policy was designed in 2017, the national health policy, the India was undergoing a clear epidemiological transition at that time. Non-communicable diseases were becoming increasingly important, while the communicable disease, maternal health problems, and malnutrition continues to persist. That we were having four problems at hand. At the same time, high out-of-pocket expenditure was exposing families to financial catastrophe. When the policy was enacted, the high out-of-pocket expenses was around 72, to the tune of 72%. Now it has come to down to around 40%. That means the policy is now making an insight that how things can happen. It has brought in the concerns into one strategic framework. It emphasized comprehensive primary health care, talked about preventive and promotive health, financial protection, better quality and care, and stronger public system. It also articulated the objective of increasing the public health expenditure up to a tune of 2.5% of the GDP. The policy importance was that it has moved the discussion away from isolated disease control program towards a health systems approach. It recognized India not only required more service, but a continuum of care connecting communities, primary health care centers, public health functionaries, and the financial, all the encompasses. The second important thing, the policy shift which has happened was the Ayushman Bharat. Ayushman Bharat is now having two different but related forms of vulnerability. It responded to the vulnerabilities which we are having. First was the financial risk with the hospitalization, for which the PMJ program was developed. Initially, it was developed to provide the cash flow secondary care, tertiary care, approximately for 12 crore people. Now it is extended to citizens above 70 years of age, and also illustrate how a program can adapt as population needs and the political priorities evolve. The other vulnerability was the weakness of comprehensive primary health care, wherein come the gatekeeper function which in the Western world they talk about. That is essentially care beyond the traditional focus on maternal and child health. Previously, we were after the Alberta Declaration, the tragedy was primary health care. Now, after the enactment of this national health policy, now we are having comprehensive health care, wherein we are providing assured 12 care packages through these institutions. They now encompasses preventive, promotive, curative, rehabilitative, palliative care, including the care of the non-communicable disease. These two pillars must be seen together. Hospital assurance without strong primary care can lead to avoidable hospitalization and escalating expenditure. Primary care without reliable referral and hospital service cannot provide continuity. So the resilience requires both this thing. The other thing which is important is the National Health Mission and the decentralized planning. India diversity makes it rigid, centrally prescribed model unsuitable because we can't be having a single model for all the country. The challenges of Bihar, Kerala, Chandigarh, Chhattisgarh, Northeast, and the large metropolitan areas are difficult. So what we did in NHM is the project implementation plan are there, which we call PIP process. It created a form of negotiated federalism, which states can identify the requirements, propose interventions and budgets, and discuss them with the union government within the broader national framework. That means it is all based on the evidences which are having. The quality of process depends on the quality of evidences used. The good decentralized planning must begin below the district level, that is, with the state and the block level disease pattern, facility gaps, human behavior, availability, service utilization, and the community needs. That's the thing which we are doing. The PIP is not an annual budgeting exercise. They have become instruments for identifying problems, measuring the expected results, and reviewing whether public expenditure actually improve services or not. The other thing is the National Program for Prevention and Control of the Non-Communicable Disease. The evidence increasingly shows that the non-communicable diseases were responsible for majority of the mortality. But the health system continued to encounter patients late after complications have developed. The policy response was to introduce population-based screening for adults aged 30 years and above for hypertension, diabetes, and common cancer, and also to integrate these services into the primary healthcare. Now we have encompasses and increased the magnitude to include the liver, the kidney, and the other diseases as well. However, screening itself by itself is not an outcome. The real governance question is what happens after screening? Is the diagnosis confirmed? Is the treatment initiated? Are medicine continuously available? Is the patient followed up? Is referral complete? A resilient NCD program must therefore is not a measure, but we see that it's not the measure of the number screen, but also the treatment coverage, continuity of care, control of hypertension, diabetes, and this. This is an example of how evidence systems must mature and forming measurable activities so that this can be. So your question was that how we are using these evidences. We are. It is common saying that if you start asking for data, the data would be collected. You start looking at the data would be measured. You start measuring the data, the things would be gone. In that way, we are trying to get evidences so that evidences can be built into practice, and that practice can be built into tweaking the health systems as well as the program implementation plan so that things can happen in one direction. That's one way. I think uh, uh, I can stop here. If there are any subsequent questions, let me know.
Yeah, thanks, Madan Gopal. I think it's highly insightful as to how, and happy also that a lot of policy making is happening on base of evidence, strong evidence. I think that's a good news, because as an outsider, we tend to go with a view that a lot of decisions happen on an ad hoc basis without supporting evidence, especially at the state levels. I mean, at the central level, you have these agencies which are giving a good support in terms of reliable evidence. Do state governments have the similar capacity when they take the decisions? Because health is a state subject and they are at liberty to take decisions at state level. Do states have this capacity, like what center has in the form of Niti Aayog and NHS?
Yeah, definitely, the state do have, as I mentioned in my remarks. I mentioned that so we usually operate through the state implementation plan. In fact, many of the states do have state planning boards, or they are in the process of creating state Niti Ayogs. That's one thing. Apart from that, most of the state, they do have program management unit or the state health resource centers. And apart from State Health Resource Center, many of the states are having State Institute of Health and Family Welfare, which is an equivalent to the National Institute of Health and Family Welfare, which was more or less building other thing, and they do the evaluation of other things. So to support the states in aligning with the broader framework of Government of India, in areas where we have to do, we try to, because the capacity levels of different states would be different. Some of those states would be better capacitated, they would be able to utilize the resources better, but there would be some states which have to depend on the external resources, donor partners and others in setting up this, who can help them in essentially in helping them in the framework. The framework is the project implementation plan. They usually take the help of the external partners and other, the state health resource centers are there, State Institute of Health and Family, state planning boards are there. They try to take evidence from there and try to see that how they can tweak in the uh, activities with evidence, so that they can ask budgets, they can ask other things, and they can see that how the broader framework which has been prescribed for achievements and for seeing the progress, they can at least adhere to that. So that capacity is there, but in a varying concept. Some they would be very fortunate, they would be having enriched kind of support, but some they would be challenged to seek support from different agencies and that kind of thing. That kind of thing is
Yeah.
there.
Yeah, just a final question. I mean, I think before I go to Himani for a related thing, how actively NHSRC or Niti Aayog or the state level bodies engage the other stakeholders, the civil society, the patient groups, or the industry, or private researchers, health researchers? How active is the involvement in that?
Involvement is quite active, because because we usually do research, so try to create evidences. If you want to create evidences, we have to see that evidences are supported. We can't be going everywhere. We have to see that when we can't go everywhere, we have to take the help of the partners who are working in the field, who are bringing in this. We usually see the partners in terms that they bring in the high-end resources, because they do have a good manpower, bringing in high-end resources. They can be at least helping us in understanding and bringing in insights, which in the normal system we won't be able to. That's one area. Second thing, we are in the process of, we usually make a lot of guidelines. Many of the states, they make guidelines. Here comes the role of the different other stakeholders, including the civil societies, NGOs, and other thing. Most of the state government, they usually have a consultative process with all these people, so that they are also brought into the system, and they also contribute to that. It's always because what the of late, what the mode of operations have been. That means all the state governments, they have a national agenda and a national framework. And most of the agencies, they are being advised that they should be seen that how they can be supporting the government in achieving the stated agenda and the objectives. So that it's a win-win situation for both the parties, instead of having a duplication of effort. So we see that how synchronization and synergies can be built in. And that's the approach. And in that, many of the people, you will be having many examples. Take the example of TB, take the example of implementation this. And you see that how we rope in the private partners. If you talk about the birth waiting homes, if you talk about the ambulance services, the MMU services, see that all involving a lot of people. And the biggest example of the cooperation with the private sector and the others is the PMJ program also, where you are having a 28,000 hospitals. You see that it's not that. If it has to be a win-win for both the parties, and the different stakeholders are also being engaged. Whenever we make it, we always take feedback, constructive feedback from the different donor partners, and that kind of approach is there. That means the it depends on how we take the things forward and how the state government approaches. But that mechanism do exist, and we do take the help of the civil society partners in this. If you have taken the example of the aspirational district program, wherein you might have seen that 112 districts were there. They were all distributed among the donor partners. You see, so many things were there. Financial inclusion was there, water and sanitation was there, education was there, when the health was there. So there was a distribution, and it was being facilitated because Niti Aayog was nudging the states and the districts. It was facilitated by the civil society and NGO organization, who in turn have managed to make a collaborative, and that collaborative is now been able to influence a lot of things. That kind of models do exist. You take the example of Bihar and Uttar Pradesh, and that kind of things are there. You see that how a common agenda can be worked out, and through that common agenda, if any stakeholders works, I think people usually go in that direction. It's a win-win.
Thanks, Madan. I think that brings a lot of comfort in terms of it's not just a unilateral decision making or unilateral evidence. There is a conscious effort at engaging every stakeholder. On the same theme, I come to Himani because her own experience in terms of how to convene these stakeholders and how to convene the dialogues around a certain issue, an unmet health needs issue, and bring a consensus, because this is a most challenging aspect of arriving at a consensus, which feeds into the decision making. Himani, I think over to you just to share your own experiences and how you are trying to balance different forces, because different forces have different aspirations in terms of what the decision should be. Over to you, Himani.
So good afternoon, everyone, and thank you for this wonderful opportunity to talk. Personally, for me, I think this was very interesting because when I started thinking of what I want to share, I also kind of saw how my career growth, how health priorities, how civil society role, how funding finance for international development has evolved over the last 25 years. So I'll just take a couple of moments to even speak a bit about that, because when I started working in early 2000s, it was still a phase where there was international aid and development which was coming. We had a lot of donors, USAID, DFID, SIDA, Canada, European Union. So a lot of these donors came and they were funding projects which where the financing from the government was not there. So the government capacity, of course, was there, but it was limited. Like Sir just said, the focus was mostly on maternal and child health, and other areas were still evolving. So the civil society at that point of time, and the funding for civil society at that point of time, was to step in and deliver services. So we were, also playing that role of the civil society was playing that role of filling the gaps. By mid 2000s, also the National Rural Health Mission came, which was big reforms from the government, and that is also the time where the government capacity and financing improved and increased rapidly. And as it was improving, the role of the NGOs actually also expanded to move a bit beyond service delivery and to support a wide variety of things. Again, I think a lot of these things have been said by Madan Gopal sir. So a lot of civil society became technical partners to the government. So from service delivery, there was a shift to technical partners. We were doing trainings for ASHAs. We were supporting Rogi Kalyan Samitis or the local institutions to build capacity. We were supporting the government in a variety of implementation, the social behavior change communication. And this was again funded by donors. So the aid money came to support the government in the implementation. So the relationship shifted. As we as civil society started working more closely with the government, I think we were also identifying a lot of evidence and also relaying it back to the government. But was it really translating into policies? We were not very sure. I would like to mention, some of, again, the donor-funded projects at that period of time very proactively looked at building capacities for evidence to support policies. And again, I was very fortunate to be part of several of these projects, which actually gave first funding to set up institutional mechanisms. So again, to share an example with everyone, a policy unit in the NIHFW was set to actually guide the government on what areas to look at for reproductive health and child. Now, the government, of course, was not investing. The civil society stepped in and built that institutional mechanism. Then, even at those early stages, there was focus and funding to start seeing, what was the process of policy making that we're talking about. And a big part of that was, getting stakeholders to come together, to, research, to speak. If we look at the national health policy, it went through a very consultative process. It went through 3 years process. I was part of the process in Uttarakhand state where we supported the development of the first health and integrated policy on health and population. It took several years. So civil society or NGOs, we played a role of going and speaking to the people to understand what were their issues. We spoke to providers, we got the government together. So, civil society over a period of time has helped shaping the policy. And now after, 25 years with, again, the new set of reforms that have come, I think our role again has evolved considerably. And rightfully so, because now, even though we may be doing similar things, the way it's organized, it's more around governance and health system strengthening. If we again take our example of the support that we provide to the governments in implementation of Ayushman Bharat reforms, we realize that, whether it is the NPP, whether it's reforms, I think the issue has moved away from policy to whether those policies can be implemented. And all of these policies are extremely complex. There is, of course, a bit of a siloed approach, but there is also a very important, realization that integration has to happen. So it's a very complex reform that we are trying to implement, and accordingly, the civil society has also stepped in. And I would again link it to funding. So the funding has also shifted. The development money is no more, is very less for on-ground activities or community mobilization. It's transitioned to more of a technical assistance / I wouldn't say advisory kind of a role. And it's again embedded, and I think majority of the civil society that today works, they are closely embedded with the government and they're supporting. So in that context, I think the role of civil society has become extremely important, because we are at a cross section where we are playing a role in development of policies. We're also actively playing a role in supporting the government in implementation. And I think that gives us a very, very unique opportunity to keep reinforcing the issues. Again, for the purpose of, giving an example, again, how are we identifying these issues? We are be able to identify these issues because we work closely with the government. And some of it is need based, some of it is donor based, from where the funding arrives. But eventually, we have been able to, bring to a priority what probably can give most impact. So again, if I take the example of the state where we have spent a lot of time, I think 2 ways of very subtly embedding policy advocacy into health system strengthening was one in the area of cancer care, and more recently in the area of, prioritizing focus on newborn and children. And here, I think we have followed the traditional ways of doing this is by constantly doing implementation research. Again, we get an opportunity to be able to interact with multiple people, which government sometimes don't. We are interacting a lot with providers, so we're bringing the provider side challenges. We are also going to the communities and bringing that perspective, and then essentially convening, in most cases, under the leadership of the government, because it's the government we want, and the government which is going to make the, the big policy decisions. So I think the most critical thing is trust, because we are mandated to support the public health programs, and trust building is, I think, what it takes time for any civil society to get seat at the policy making, at the implementation phase. And I do agree there are a lot of priorities, but we also know that policies per se are statement of intent. And I think that's a very good beginning for this governments, that at least their intent has a very broad-based view. And with time to time, as resources comes in, as capacities come in, then issues and priorities can be really taken off. Again, just maybe to conclude, I would say that one, civil society, increasingly this role is becoming very important, because we actually have very fewer resources on the ground. So our role is to bring those voices to the government, and really bring that perspective. The second thing is to be able to identify champions who can bring in neutral perspective and experts. I think that has also worked very well. So organizational credibility, bringing the right people to come and bring that perspective to the policymaker. And I think a lot of patience and perseverance, because it's right, there are so many things which are happening and everything is a priority. But then there needs to be an organization which doesn't let go. If it took us 2 years to keep following on cancer care prioritization, I mean, that's a mind frame we need to have. It's not going to happen in a day. And finally, I think being able to create actionables for government from these policies, dialogue and discussion, I think that's the most important, because that's what even Madan Gopal sir said, that how is it helping me now improving my policies, which I can start implementing. So very clearly near-term actions for the governments which are doable, and while keep supporting them on building evidence and whatever is needed for long-term advocacy. So I'll stop here. I think our role has evolved a lot, and probably in coming times it will evolve more.
Yeah, just one question before I move on is how do you balance the pressure of the groups? I mean, sometimes it may be a development partner, or it may be a sponsor, or it may be another group. What guides that balancing between what makes patient's interest ultimately has to be the primary thing. At the same time, if the sponsor's interest is not aligning with patient interest, or not aligning with the given country or the state interest, do you still accept the dialogue around that context? Because we do come across some of these things, that there is a pressure.
In the health system strengthening framework. And again, I would think that consultations and convenings are about different perspectives, and it's all right if we are not able to bring consensus all the time. But the important thing is that all the stakeholders, or whatever evidence exists, people are able to bring that together. Also, I don't think so any policy action ever takes place as a result of a convening, or one convenings or two convenings. It is about socializing an idea and concept, and then really, building it over a period of time. Especially in context to, the pressure from donors. It is there, but I think even donors really cannot, they can say that to us one-on-one, but they really cannot really put that pressure at a platform level. If in this group we have 4 panelists and they have their views, we may not all agree on a certain thing, but it's okay to hear those views. And again, I think it is still what is best for that program, what is best for that people gets picked up, and it can be actioned. But I would again think we want to create that trust and credibility of being a neutral. We have to be a convener. So the objective is to get different people to come and talk. We really need to build that skill to be not get carried away by any one stakeholder, but try to keep that balance. It's a difficult act, but I think so far it's worked.
Yeah, thanks, Sonia. I can understand this challenge. Moving on to Bhuputra, more as a researcher, because as a pure researcher, your interest is in generating objective evidence, the truthful evidence. That is one thing. The second thing is presenting that evidence in a way a non-technical person can understand, because I think that is one of the competencies as a researcher, policy researcher, that you need. And the third is, of course, how do you, as a researcher, I mean, whether the research is done to inform policy where, as a researcher, you feel strongly about it. So I'm only probing the mind of a researcher in the policy making process. Bhuputra, over to you. I think just your perspectives as a researcher on policy process and how actively it is being sought in today's terms. Because, I mean, we also are evolving into a mature governance systems, how it is maturing.
Thank you, sir. Good afternoon to all of you. At the very outset, extremely happy and thankful to you for giving this opportunity. And thanks also for organizing and anchoring this session for today's discussion. It's a very important question. And when I was asked to talk on this topic, I was actually very closely examining in last 25 years what I have done for the sake of science and evidence and what has been useful and what has not been. So to summarize, before I summarize as to what is being willfully deployed by the government and accepted by the government, what is not, let me come back to the basics of what Emani spoke about, the policy, the statement of intent. From there, it is theoretically talking about the different dimensions of policy making. It is a very complex process and it is contextual in nature. It varies from place to place. Within federations, especially in the United States, the policy making and implementation processes are extremely different than what it is in India. Because for that matter, in any democracy, the policy making process is a very, very complex and consultative process, driven by a multitude of actors, sometimes pressure groups and sometimes non-state actors. So agenda setting, prioritizing, and also finalizing the policies is a very Herculean task. We've seen this in terms of the public health policy in our own country over a period of last, say, 40, 45 years, how it evolved in 1983. And government of the day had to have that strategic shift because of a number of factors. One of those important factors is the evidence that has been presented to them from time to time. And organizations, starting from think tanks to research organizations to academic institutions, all of them have played very important roles in shaping the policies of the day. From the primary healthcare of 1983 to the Greenfield research in 2017, the shift is gigantic. Now coming to our own experiences of conducting research, generating evidence, and negotiating with the government as to whether it is to be accepted or not. My own experience has been a mix of some successes and some failures. Many times, studies which are being commissioned by the government typically evaluation studies. Let me also here say, for the sake of the larger audience who are participating in the discussion today, we are broadly talking about 4 types of policies: the regulatory policy, the constituent policy, the reconstituent policy, and the allocative policies. Now, evidences, generation of evidences, synthesis of evidences, and utilization of those evidences for these 4 categories of policies are also going to be distinctly different. For example, in our Indian context, policy making is more of a popular process than typical hardcore evidence driven so far. I mean, until at least 2000s, late 2000s, you can say. But in the European context and in the American context, it's very, very different. The federal government of the United States continues to look for deploying organizations, engaging with organizations for generating evidences on the basis of which they decide the policy prescriptions. So for that matter, in the European Union also was spending a lot of money for generating evidences for European policies on health sector. I distinctly remember some of the papers published by Julia Fox-Rasvai and Anne Mills from London School of Hygiene and Tropical Medicine. They shaped the European policies in public health to a great extent. But in India, I think of late it is coming up now. And especially those studies which are being commissioned by the government with a specific purpose in mind, the findings of the study are normally being brought to the table for discussion and refining of the policies. And also here, let me also say, typically evidences are being generated for supplementing the policies from 2 perspectives: dissecting an existing policy and formulating a new policy. As policies run through a typical 3-phase cycle of policy formulation, policy prescription, policy implementation, and policy evaluation. So research becomes an important tool in all of these 3 phases of the policy journey. The prospective evaluation that is being carried out for shaping a new policy, and the retrospective evaluation which is being carried out for identifying the successes and the failures of an existing policy, both are relevant for the government stakeholders. So Niti Aayog, for example, I mean, let us talk about the NHSRC 2005-6. They gave recommendations for bringing about gigantic reforms around the HMIS, the Health Management Information System of our country. It's such a big country, we are not able to generate timely information about certain processes and certain outcomes related to health in our country. Now, when you look at this HMIS evolution that has taken place on the basis of the NHSRC recommendations, from 2006-7 today we are 2026, 20 years down the line, we still have a long way to go. After the implementation and success of CoWIN application, Government of India is now talking about, through the digital health mission, talking about digitizing healthcare services to a great extent. But 2 decades have gone by. The evidences are still being applied in bits and pieces. Whereas on the other hand, the initiation of the NHRM itself, the NHM, today's NHM, was based on the evidences that were generated around the 2000s by multiple institutions engaged in public health research. So the successes and failures of the evidences feeding onto the policy making in India has been a mixed bag. At least that is the experiences that I have with me until now. But certain state governments which are more open, the ministries, the legislative processes, and the bureaucracy, the administration, as such, open to learning, open to discussion, open to negotiation and sharing, they become proactive in making policies. For example, the COVID management we studied for Odisha. How COVID was being managed by the government of Odisha. That study was commissioned to us. We studied it and gave a comprehensive report in terms of whether the decisions taken with respect to lockdowns, shutdowns, whether they were corroborating with any of the scientific evidences related to the spreading of the virus, or whether it was purely based on the experiences that was being gathered and supported through media from Europe and elsewhere. So the evidences indicated that Odisha government was very much preemptive in its approach towards curtailing COVID-related damages. Whereas if you compare this with few other states, where probably the decision-making process was not as preemptive or proactive as it was in Odisha, probably the loss of lives were more reported more as compared to Odisha. So there have been instances where governments have taken decisions very proactively on the basis of evidences generated by research organizations with respect to a particular specific research question in mind. And there are also instances where governments have not been mindful of the evidences that are already available with respect to a particular theme in question. Another example is the COTPA Act, the Cigarette and Other Tobacco Products Control Act that came up in 2003. After the FCTC in 2007, it was modified and it is being implemented for last 20 years in our country. Hriday being one organization, civil society organization that continuously worked on this theme. And they submitted evidences to the government as to how the COTPA Act, certain sections, Section 4 and Section 5 of COTPA Act is being violated again and again by different tobacco manufacturing organizations in our country, and in fact also by the cinema of the country. The movies that are being released to the theaters, they were also not following the COTPA Act guidelines. So ultimately, on the basis of the further investigation of these violations, Government of India was made duty bound to act on it. In fact, the Supreme Court of the day also came to the rescue and tightened the grip around implementation of the COTPA Act. Another example I can give you is the trend set by Surge, Dr. Abhay and Rani Bagh in Gadchiroli, Maharashtra. That model that led to a series of Lancet publications as to how a 8th standard, 10th standard pass out from a village lady can be trained to become an efficient lifesaver for infants and for women. And that actually led to initiation of this, what is called the home-based newborn care by Government of India. Government of India introduced this policy of SBNC on the basis of the findings of this Gadchiroli model. So there have been instances in our country where hardcore evidences have fed on to the policy-making program implementation. And there have also been instances, our own work on supportive supervision in Odisha that led to laying the foundation stones for supportive supervision on routine immunization by the Government of India. So there have been such instances time and again where evidences have led to policy making, and on the other hand, there are also instances where some of these policies have been more populist driven than evidence based. So this is briefly the summary of the question that you asked on the application of evidences for policy making.
Thanks, Bhuputra. I think you gave a very, very clear perspective on how it is evolving in terms of evidence generation and its utilization by the policy making and policy implementation side. In the remaining few minutes, I mean, I had actually second round of questions, but the first question itself has elicited good responses. As I mentioned in the beginning itself, I mean, we are not worried about continuing these discussions in the series of P2P learning sessions. So I may invite some of you again back to answer some of the questions that remain unanswered. So before we have time to take up some of the questions that already came up in the Q&A box. The first question, I think, to Dr. Hala, I think, is because, as you mentioned, I think one of the key determinant of implementing your hepatitis policy was the cost of hepatitis C drugs, what was prevalent in the US and Europe versus what Egypt can afford. So the question, I think, one of the questions from the participant is, how did the pharma rise up to that occasion? I mean, how did the government and the policy makers take that into consideration? Because if you were to go with the prevailing market prices in the globally, then the budget would not have been sufficient to eliminate hepatitis, the 200 million or 300 million budget that we sought from the World Bank. So the question is related to that. How actually you translated the policy into action on the aspect of the cost?
Yeah, thank you, Dr. Reddy, for this questions. The issue is the communication and how to share the people in the decision for medicines and for diagnostics also. For medicines, the pricing of the medicines in Egypt is obligatory. It is the government used to, or the Egypt Drug Authority used to price the mandatory price for the registered medicines. So according to, we used to put in our pricing model a lot of aspects, including the cost of production, the labor cost, the material, the APIs, the depreciation of machines, everything. So based on this, we put the cost. But to convince them to deliver or to supply you with this cost or this, to be honest, the cost was not, or the price was not $39 US per course. It was 100. But I did the negotiation by myself with the manufacturer, with the medicines chamber in the industrial union. I did the negotiation because we will send their PO in short time to for mass production, and versus that they will earn a lot of money because they will guarantee the demand. But meanwhile, I invited the API manufacturer from India, which is the CEO of Optimus in Hyderabad, to come to this panel of negotiation or session of negotiation to convince him to reduce the price of the APIs. He told me that to reduce, you need to negotiate with the China because you used to go to China to receive the mediator. The mediator from China to India supplying us with APIs. And then, so I went to China with the API manufacturer from India and with the manufacturer from Egypt to negotiate on the price, to make sure that the cost of production will be satisfied, the margin of profit will be satisfied for the end producer, you know, and for all the people. And we ordered for more than 4 million, according to the prediction and forecasting. We forecast that we will order for 4 million at least, 3 months course for 4 million patients. And we succeed to send the PO for all the manufacturers. So this is very important. Let me, before closing this, because again, this is for medicine, but for diagnostics, we reduced with the negotiation the cost, the price of the rapid test from $4.7 to $4.7 per kit to $0.57 per kit, because we will receive or we will order the output with at least 60 million in 7 months. So with this type of procurement, they can reduce the price versus negotiation. Let me to share you updates. Yesterday, the government announced on a very important figure and indicator. This is, and they mentioned this is the result of 100 million healthy lives campaigns, because 100 million healthy lives campaigns is not only virus C or hepatitis C or non-communicable disease, it's the breast cancer, it's the children, the school from anemia and stunting. It's a lot of initiatives that's still running till now. The indicator is that Egypt has been a substantial decrease in cancer matrices between 2022 and 2024. Age standardized cancer incidence dropped by 17.2%, while mortality rate fell by 23.5%. This decline is largely credited to sweeping national healthcare initiative, particularly 100 million healthy lives campaign. So why this happened? Because early detection, because the predisposing factor like obesity, diabetes, you used to early detect and treat, because the early detection of breast cancer. So whatever public health initiative is the right preparedness, not only for universal health coverage, but also for any pandemic in the future. Thank you.
Thanks, Dr. Hala. I think there are so many questions, but they pertain to implementation, which will be coming up as a next series from policy formulation to policy implementation. Just one question from my side to Dr. Madan Gopal. On the policy of universal health coverage, the government has been struggling to take a policy decision on the missing middle, the 500 million people who do not have any financial protection. And I understand, I mean, I remember Niti Aayog also convened a lot of evidence generating research. Despite, I mean, I think there is significant evidence, but this pertains to the dilemma between different options for the government. So, Madan Gopal, your just perspective before we come to the closure of this 90-minute session on this aspect of it, especially your take on this missing middle as a evidence generator or as a consultant. What is your advice on that?
In fact,
The question was not asked earlier.
no issues. No, because I'm very happy that at least you have put this question, because I was the person who was responsible for bringing this narrative of this missing middle population. I think the report which you have mentioned, the Manthan Shiv 2018, when we had a conclave along with Access, at that time the development dialogue, the health system dialogues were there. In that, one of the component which came was the missing middle. Then we had an elaborate session on missing middle. We brought out a report on missing middle that's there. I was chairing that committee at that time. So we brought that report. But one of the dilemmas which is there, though the intent is there, the contest is there, everything is there. But the main problem with the missing middle is that who will pay for the premium for these people? That's one thing. Because if you talk about the Ayushman Bharat Health and Wellness Center and the other program, services are free across the country in most of the government. The FDSI initiative on this free of cost. But the problem is whether the people will be going there, the behavior, the health seeking behavior is different of the middle class people. They want to have a high end thing, but though the free services are available, that means that financial protection available is there. But if you talk from the insurance perspective, whether financial protection is there as compared to the other vulnerable section which are covered through PMJ, the secondary and the tertiary care. In that case, we have explored many options. The options where they can pay. How much they can pay, that was the question, and it was agreed. We came to a conclusion that they can pay up to 10,000, 12,000 rupees per annum for coverage of 5 lakh rupees. That model was there. IRD also come up with the different models for bringing in them in the net. But when we interacted with many of the insurance companies during the course of making that report, then realized that most of the insurance companies, they can provide this kind of insurances based on the volumes which has to be assured to them. That's the bottleneck. Awareness is there, everything is there, but who will generate volumes? Because in a country where the competition commission is there, everybody is there, it has to be transparent, accountable, and people should know that fair competition has happened. I can't be assuring I can't be assuring and ensuring saying that you would be getting a fixed volume of services. Whereas in the Western world, what happens that whole of the people, whole of the population, they subscribe, and the subscription is given to somebody to manage. But here, I can't ensure subscription of anything. That's why, in a graded manner, I think the policy dialogue has started. The seniors above 70 years, they are covered en masse, irrespective of their insurance status, whether they are covered in other, they can avail it. Slowly and slowly, that thought process has started. I think coming days you would be hearing the age relaxation might happen for the coverage of that thing based on the experience and based on the evidences which we generate. Because Other thing which is stopping us is the actual things. We are still have to building the capacity for the actual estimations for covering all this kind of things. So that means one way we are building the capacity, the other way we do have a policy note. We are trying to see that how we bring the missing middle into the bigger fold of the health insurance gamut. That's a challenge. I think in the coming days, with the efforts of all, I think we will be finding a solution for that.
Thanks, Madan Gopal, and I think I thank all the speakers for a wonderful. I think all the participants agree that it was an enriching discussion, especially from a practitioner's point of view. I mean, we do read a lot of theory related to policy making, but when it comes from actual practitioners, it is much more richer. I think that is the objective of this series. As I mentioned, I mean, there are a lot more questions to be explored on the same theme of policy making with real-world examples. So we will continue this series, and I haven't taken up. Some of them are comments, but some of them are questions, but not relevant for today's context because we'll be continuing this discussion going forward, especially in terms of the implementation aspect of it, like how you decide about allocations, resource allocations, how you decide about the capacity of the system to implement. Sometimes you give financial allocation, but capacity is not there. So some of to the implementation process, and increasingly, I think most of the countries are now depending and putting into place a lot of implementation research to guide the implementation itself. So these are some of the other areas of, I mean, I'm taking the governance cycle. We started with assessment, monitoring, surveillance to inform strategy, policy, and actions. So we covered the policy aspect of it. In the next series, we'll cover how the strategies, how do we advise strategies? I mean, how do we come up with strategies? I will invite some of the people who, administrators of the policies, who will be tasked with coming up with strategies because they have 4 options out of that, which strategy they have to select. So that will be much more richer in terms of how do you actually do that strategy thinking before you develop a detailed planning. So we will explore those 2 subjects beyond the policy making in the next series, and I might invite some of you as well back to the discussion according to the questions that I will be framing. Thanks again, and participants, again, apologies if we didn't give time, but the discussions were so interesting. I didn't want to interrupt the speakers. Apologies again, and see you next month.